Dear colleagues, it's a pleasure today with Jean Connors and Jim Ducatis, and on behalf of all my colleagues from the International Thrombosis and Cancer Initiative and with the ISTH, to participate in this educational case-based series. And I would address with you the difficult question of treatment and prophylaxis of catheter-related thrombosis in our patients with cancer. At the end of these modules, we hope we'll all be able to describe the 2019 ITAC clinical guidelines for the management of patients with cancer and establish central venous catheter-related thrombosis that we'll call further down CRT, if you allow me. And we shall be able to differentiate what the clinician needs to do in daily practice for the early maintenance treatment of these specific CRT up to 3 months and the long-term treatment beyond 3 months, as well as patient monitoring. For these aims, we need to select the appropriate therapy and the duration of treatment for each single patient to treat adequately in accordance with the ITAC guidelines, the central venous catheter-related thrombosis. Why this question is so important? Because it is common for our patient. We know that the incidence of symptomatic CRT, central catheter-related thrombosis, is reported as 1% to 28% in cancer patients. So why such a variability? Probably because there is a large difference between symptoms and asymptomatic patients, and this explains the variation. The more we look for it, the more we find it. And maybe from time to time, clinical examination is insufficient. However, it also leads to dysfunctioning catheter. And it also leads the onset of CRT to the onset of pulmonary embolism in 10 to 15% of the patients who may have CRT. So this is a critical point. In addition to that, the onset of CRT may lead to the loss of central venous access in 10% of the patients, although they require critically the use of their CVC. When we're dealing with peripherally inserted CVC, that we call PEEK, the removal of the PEEK is necessary in 3.4% of our cancer patients. So this is a critical question in daily clinical practice. To diagnose the onset of CRT, we have to understand the physiopathology and to be able to remember that per definition, CRT is a mural thrombus extending from the catheter into the lumen, whether it is at the sleeve thrombus or whether it is a mural thrombus, but this importantly should be differentially diagnosed from dysfunctioning of the catheter, which may be associated with the onset of a fibrin sheath or a distal thrombus at the tip of the catheter, and these clinical situations are falsely called central catheter-related thrombosis. We know that there are several risk factors that we shall detail, which can be related to the insertion of the catheter, whether it is a peripheral central venous catheter or a port, an implanted port, whether the central venous catheter that we call CVC is inserted on the subclavian site or on the jugular site, where the risk is lower, and whether there are abnormality in the coagulation, which can be evidenced by the increased level of D-dimer levels after insertion, which has been used to try to predict the onset of CRT. There might be in some patients some abnormalities like factor V mutation or prothrombin mutation, which may enhance the risk, but very few data have been obtained in the literature. And we know that we have no evidence today as to the weight of cancer per se related factors which may influence the onset of CRT in cancer patients. So in conclusion, all the risk factors are mostly related to the catheter per se and the way the catheter is being positioned and indwelled in the patient. In this large meta-analysis by Jung et al., recently published, which has gathered 80 studies and more than 39,000 cancer patients who developed venous thromboembolism, comparing those with and without venous thromboembolism in all these patients bearing implantable venous access port, we can remember two important messages. The number one, the weighted frequency of symptomatic venous thromboembolism in these cancer patients with central venous catheter is around 2.7%, which is far from being negligible. Importantly, and this is a key message, the risk associated with central venous catheter thrombosis is lower in those patients who are being implanted with an access port as compared to those who are receiving a peripherally inserted CVC. And among those patients with central venous access port, what we see on this picture is that the site of insertion, and namely again jugular vein as opposed to subclavian vein, is importantly associated with a lower risk for the jugular vein as a higher risk for subclavian. Therefore, if we have a single patient in front of us and we know we shall be obliged to insert a central venous catheter, we need to think ahead so as to prevent as much as we can the onset of a central venous catheter associated thrombosis. And we have to remember these risk factors, the fact that more than one attempt to insert the CVC is the highest risk. We should have a senior doctor implanting the catheter. The fact that the cancer patient has already undergone previous CVC insertion, this should be remanded, and on which side. The fact that the central venous catheter will be inserted on the left side as opposed to the right side where the risk is lower. And the position of the central venous catheter, importantly, it should not be at the superior vena cava. It should be well positioned in the right atrium and at the junction. And the fact has previously assessed that peripherally inserted catheter are at much highest risk than central port. So let's go to the clinical practice. We are now facing our patient who is suffering from early breast cancer, being diagnosed in this 64-year-old woman, which is slightly overweight and has no comorbidities. She was diagnosed with a stage 2 estrogen receptor and a HER2 positive tumor on the left breast. This is important because we have to think of where we're going to put the central venous catheter. And note, the CVC is necessary because she has to undergo chemotherapy through a port cath, which is being positioned because she has a left breast cancer on the right side, but in the subclavian insertion. Remember, it's not jugular. So she has a slight risk, but it's on the good side. She will undergo a mastectomy with axillary lymph node dissection, and then she will undergo surgical reconstruction with free flap reconstruction, which is planned. Which are the risk factors for onset of venous thromboembolism, VTE, in these early breast cancer patients? We know, as previously revised in this series, that there are specific cancer-related factors related to the site of cancer. Here's the breast cancer, the histological grade, the tumor node and metastasis staging that we shall know after surgery. There are individual risk factors, previous history of VTE, there's none here, advanced age, our patient is not so young, obesity, she is slightly overweight, immobility, she will be immobilized during surgery, and we know nothing about whether she's bearing prothrombotic variants, and other comorbidities, apparently not. What we know is that due to the existing early breast cancer, she will undergo chemotherapy, and that the annual venous thromboembolism incidence will be 6% in those patients with breast cancer receiving chemotherapy and will increase to 10.8% fold higher during chemo as compared to patients who would not receive chemotherapy. The patient will undergo surgery, so we know that the risk of onset of VTE and of central venous catheter associated thrombosis will be increased in the first months after surgery, but not after the first month. So we have to be very careful. But after the first month, other risk factor will occur because we also know that the risk of onset of venous thromboembolism is higher 3 months after initiating tamoxifen as compared to before. And in this woman who is sensitive to estrogenotherapy, she will require either the addition of tamoxifen or maybe of other aromatase inhibitors. And we know that with aromatase inhibitors, the risk is not higher as compared to those who do not receive. What do we do with our patient? How should the central venous catheter be placed? It should be placed on the right side and in the jugular vein, but we have noticed that it's been placed in the subclavian vein, so the risk may be different. In addition, we have a good anesthesiologist who is placing the central CVC at the good place, which is that the distal extremity of the CVC will be located exactly at the junction of the superior vena cava and the right atrium, and this is of utmost importance as clearly underlined in the ITAC guidelines with a grade 1B level of evidence. So we suggest that you download the guidelines and you refer to them, and you will find them easily on the app that you have downloaded on your telephone or on your computer. Our patient is now bearing a central venous catheter inserted. Does she require prophylaxis of CRT after placement? The evidence is no, and it is a high level of evidence, a grade 1A level of evidence. The use of anticoagulation for routine prophylaxis of CRT is not recommended as underlined by ITAC guidelines. And we all know that there is a risk when we use prophylaxis, even prophylaxis with any anticoagulation, which is the risk of bleeding that have been assessed by all colleagues and all of us. So our patients will undergo chemotherapy. We know that in these early breast cancer patients with central venous catheter, the chemotherapy will strongly increase the risk of onset of venous thromboembolism. With cancer alone, this risk is 4 to 7-fold risk. The addition of chemotherapy will increase the risk of VTE 6-fold and of recurrent VTE by 2-fold. And therefore, at the end of the pathway of treatment for our patients, the annual incidence of VTE in these cancer patients undergoing chemotherapy is around 10.9%, which is very high risk. So again, our resident will ask us, does she require VTE prophylaxis during chemotherapy? We can explain and underline that no, primary prophylaxis with either low molecular weight heparin, VKA, or DOAC in ambulatory patients receiving systemic anti-cancer therapy is not recommended routinely. And this is a grade 1B level of evidence. We have had a lot of clinical trials assessing the need or the contraindication for prophylaxis of venous thromboembolism in these patients over the past 20 years. And what have we understood? That primary prophylaxis with DOAC or with low molecular weight heparin is not recommended routinely. However, that DOAC using either rivaroxaban or apixaban may be recommended in some specific patients who are ambulatory and receiving systemic anti-cancer therapy, but specifically those who are at intermediate or high risk of venous thromboembolism, defined by their cancer type, has Jim Ducatis assessed pancreatic treatment, or by a validated risk assessment model, which has been extensively studied and described in the series of ISTH using the Corona score above or equal to 2, and we refer to this teaching course. But importantly, and as derived from the ITAC guidelines, in the cancer patients who may be requiring, according to these prior requisites, potential prophylaxis of VTE, they should not be actively bleeding nor at a high risk of actively bleeding. Therefore, let's go back to our patient. Does she require prophylaxis during the chemo? We saw no, but now she is going to undergo mastectomy or further surgery. Should she undergo perioperative CRT prophylaxis for the mastectomy? The answer is yes, because we know that she should be managed perioperatively according to the guidelines. She should receive either low molecular weight heparin once daily, unfractionated heparin 3 times daily, and we also know that this should be started 12 to 2 hours pre-op and continued for at least 7 to 10 days. Which are the ITAC guidelines and the worldwide guidelines, as in other guidelines, ASCO, ASH, and any national guidelines, we all agree that in surgical cancer patients, prophylaxis of onset of VTE is of utmost importance and should be performed using either low molecular weight heparin once daily or unfractionated 3 times daily, started 2 hours to 12 hours pre-op and continued at least for 7 to 10 days, and that the highest dose of prophylactic low molecular weight heparin should be used. And this is a grade 1A level of evidence according to the guidelines. Some patients should undergo, most of the time, extended prophylaxis for at least 4 weeks to prevent post-op VTE after major laparotomy, which is not the case on our patients who will undergo breast cancer surgery, and that in this setting, the mechanical methods are not recommended, neither the insertion of inferior vena cava filter, and this with a high level of evidence. So let's go back to our patients with early breast cancer who has undergone a mastectomy, and we are 2 months later, and all at once, she has some symptoms on the arm, and a right ultrasound examination of the subclavian vein has confirmed by a CT scan is revealing an occlusive venous thrombosis. However, although she had slight pain, the central venous catheter is still functional, it is not infected, and it has been checked by an X-ray and it is well positioned. However, because of the diagnosis of CVC-related thrombosis, CRT, we know that the patient has to have a breast reconstruction which is being delayed. What do we do with the central venous catheter? Should we remove or not? Concerning the CRT treatment consideration, how should we manage our patient? If she has onset of thrombosis, should we treat with unfractionated heparin, low molecular vitamin K, fondaparinux, or DOAC, or any other position? So how to remember all these tricky questions? We just need to download the app and to have a look at where does the pathway guide us, and if we skip from one position to the other one of the algorithm, we have the clear answer. No, we don't need to remove it because it is well positioned, it is functional, and it has not been infected. So now, how do we manage our patients? We look at the app and we see that we have to treat her with low molecular weight heparin, but these are suggested. And we also learn that the ITAC guidelines are modelized in this app, which is accessible for free on the internet, that you can download at Google or Apple Store, and that there are direct comparison in the level of evidence concerning direct comparison between low molecular weight heparin, DOAC, or vitamin K antagonist in this setting is still to be made, so it's just a guidance. We understood that because this patient has had a central venous catheter-related thrombosis, we should maintain the treatment with anticoagulation at least 3 months and as long as the CVC is maintained in place. 4 weeks after, this patient's symptoms have largely resolved, but she still requires to have central venous catheter access. So how should we manage our patient? Should we leave the CVC in place and continue anticoagulation treatment for a minimum of 3 months? Should we continue the anticoagulation as long as the CVC is in place? Or should we stop the anticoagulant treatment? What would happen if, after 4 weeks, the patient's symptoms have not resolved, although the catheter is still well functioning, but she still has symptoms? Therefore, we download the app and we know that because patients still have symptoms and she has been correctly treated with low molecular weight heparin, we definitely have to remove the CVC and to continue the anticoagulation treatment for a minimum of 3 months. And for that, if we would have forgotten, we just have to clip the app and to see that after 2 to 4 weeks, with a functioning central venous catheter still functioning, but if the clinical symptoms have not resolved, we should definitely continue the treatment by anticoagulation. In summary, CVC are commonly used in all patients with early breast cancer due to the need of chemotherapy. We remember, and this is a level of evidence in the ITAC guidelines, it is of importance to insert the CVC on the right side, ideally in the jugular vein where the risk is lower, and importantly, that the distal extremity of the CVC should be located at the junction of the superior vena cava and the right atrium. We should not use anticoagulation as routine prophylaxis for CRT, but once an established CRT occurs, the low molecular weight heparin should be used for a minimum of 3 months. In this delicate setting, if the CVC is functional, if it is well positioned and not infected, it can be kept in place, which is of utmost importance for our patients who need the use of a CVC, but we should monitor clinically the patients very regularly and ensure that there is good resolution under close surveillance of all symptoms. What about the onset of an established central venous catheter-related thrombosis in a cancer patient? Our second patient is a 71-year-old woman who is very thin, 25 kilo square meter BMI, because she has unfortunately been diagnosed a mass ascending in the colon with elevated markers, and the biopsy has confirmed the diagnosis of an adenocarcinoma. Therefore, she will require neoadjuvant chemotherapy, and of course, first of all, a central venous catheter will be placed in these patients. 2 months after the catheter insertion, the patient developed a non-inclusive thrombus of the superior vena cava, and this is confirmed by the CT scan examination. Our patients still have a normal renal function, and we ensure that the creatinine clearance is above 30 milliliters per minute. The nurse confirms that the catheter is well functioning, and we know that the patient requires continuous central venous access. What should we do with our patient? Should the CVC be kept in place? Yes or no? What anticoagulation should we initiate in this treatment? Low molecular weight heparin, vitamin K, or DOAC? Let's have a look at the app. It's easy. We have the whole answer. We squip. The patient has no septic thrombophlebitis. She does require maintained continuous central venous access. The CVC is well functioning. We know that she does not have severe vena cava syndrome, and we know that her creatinine clearance is above 30 milliliters per minute. Therefore, we can use what? The low molecular weight heparin. We have to consult the monography from the site, but importantly, we can keep the CVC in place. Yes, we can and we should, because it is well positioned, it is functional, it is not infected, but only if we are ensured that good resolution of the symptoms will occur and that we'll closely check our patients while anticoagulation therapy is administered. However, in this specific situation, we have no standard approach in terms of duration of anticoagulation, which has been established by prospective clinical trial. Therefore, we shall initiate the treatment with low molecular weight heparin. This is a guidance. We know that direct comparison between low molecular weight heparin, DOAC, and vitamin K antagonists have not been made yet, so we remain in a guidance, and we'll do as our patient and drug availability on site is feasible. After 2 weeks of anticoagulation, we are happy, and the patients more, because symptoms have largely resolved. She does well tolerate the low molecular weight treatment, and there are no other any contraindication for low molecular weight anticoagulant therapy. What should we do? We are 2 weeks after starting low molecular weight heparin. Should we continue low molecular weight heparin for a minimum of 3 months? And as long as the CVC is in place and see our patient again in 3 months? Should we continue for a minimum of 6 months? Or as long as the CVC is in place and reevaluate in 6 months? Should we stop the anticoagulation because symptoms have resolved? Let's see what the app suggests. So, we squip, yes. The functioning catheter, yes, she has been treated for low molecular weight heparin. She does tolerate low molecular weight injection, and she is willing to continue. So, the level of recommendation is continue and reevaluate in 3 months. On the other side, we could imagine that the patient will not have good evolution and that she comes back with chest pain, confusion, and swelling of the face and the neck. What will occur? We immediately diagnose a severe vena cava syndrome. What should we do? Refer to an expert center for thrombolysis, modify or continue anticoagulation treatment, insert an inferior vena cava filter, A, B, or all of the above. Well, we are far away from the reference center, so let's have a look at the app that we can download for free. We know that the patient is starting the treatment of a central venous catheter-related thrombosis, that she has no thrombophlebitis. She does require the maintenance of the indwelling CVC. The catheter is well functioning, but she has developed severe vena cava syndrome, and therefore the recommended treatment is to consider thrombolysis to be conducted in an expert center and that the anticoagulation is needed if the thrombolysis is not performed. So therefore, we see that the app can save us when we're in difficult questions, when the clinics starts to be complicated, and we rely on A or B because this is the last level of evidence ITAC guidelines. What if now our patient would develop renal failure with a creatinine clearance at 25 milliliter per minute? Should we remember that we have to stop low molecular weight heparin and go to the use of unfractionated heparin for at least 5 days and relay along with vitamin K antagonist? Should we decrease the dose of low molecular weight heparin and use prophylactic dose, or should we just cease the anticoagulation or use A and B? Let's have a look at the app. Everything is easy because now we can go along the path and we go to the patient case. She has creatinine clearance below 30 milliliter per minute, and therefore we immediately get the answer. We should use therapeutic dose of IV unfractionated heparin for at least 5 days and relay with vitamin K antagonist. And there is no other solution because in the presence of severe renal failure, as defined by below 30 milliliter per minute, we suggest the use of unfractionated heparin and early vitamin K. What if after 2 to 4 weeks follow-up, the patient reports having struggled with daily injection of low molecular weight heparin and does not wish anymore to continue these drugs? Should we propose transition to the patient with vitamin K antagonist? Should we switch to DOAC? Should we cease and stop the anticoagulation and switch to mechanical prophylaxis as a monotherapy? The app can help us. What about the ITAC guidelines? We know the pathway now, and we immediately understand that if the patient is not willing anymore to continue the low molecular weight heparin, therefore, we may transition to the vitamin K antagonist or to a direct oral anticoagulant and relate to the drug availability on site and the notice. But anyway, the anticoagulant treatment should be maintained for at least 3 months and as long as the central venous catheter is in place. And wherever we are on the planet, we have to address to the country-specific DOAC or VTA drug product monograph and dosing recommendation because ITAC, International Thrombosis and Cancer Initiative, delivers documentation worldwide for easy access to anybody, but we have to rely on our own nation delivery of drugs. As take-home message, what should we remember? The number one, the presence of a malignancy is a major risk factor for VTE. We know that for 20 years, but the placement of a central venous catheter in these cancer patients, which was first addressed in 2013, when we started the International Guidelines Initiative, is of utmost importance because these patients have a high risk during the surgery, but during the systemic anti-cancer therapy and due directly to the placement of CBC. Number two, there is no indication for prophylaxis in those cancer patients undergoing chemotherapy or those who have a central venous catheter. Last but not least, for patients with established diagnosis of central venous catheter-related thrombosis, the anticoagulation is recommended for a minimum of 3 months and as long as the catheter is maintained in place. And for that, the use of low molecular weight heparin is suggested.